Hello, welcome. I'm Dr. Tony Magliocco, and I'm the Cancer Informant. Welcome to today's episode. The Cancer Informant is a series of podcasts that have been created to inform patients about cancer. They are intended to be non-commercial and informative. I hope you enjoy them. Today's episode will be focusing on prostate cancer. Prostate cancer is a very common cancer in men. It's in fact the commonest cancer that can occur in men. Prostate cancer can affect 1 in 7 men over the course of their lifetime. One of the problems with prostate cancer is it can be quite variable. It can be indolent or it can be extremely aggressive and lethal. And this makes it somewhat challenging to both diagnose and manage. Now, the prostate gland is located underneath the bladder. It can be affected with both benign and malignant conditions. There's a condition called benign prostate hyperplasia. In this condition, for unknown reasons, the prostate gland will enlarge and swell, and this can cause obstruction of urine flow. This can lead to frequent urination and difficulties with urination. Treatment for this condition can be what's called a TURP, or a transurethral prostatectomy, where the obstructing prostate can be cored out to allow the normal flow of urine from the bladder through the prostate. Now, malignancy is obviously a serious problem when it affects the prostate gland. How can malignancy be detected? Well, one way is by digital rectal exam. So when a patient or a man goes for a routine physical exam, the physician may examine the prostate gland via a digital rectal exam. The physician can palpate and feel abnormalities in the prostate gland, which can indicate that there's an underlying lesion or an underlying cancer. Another technique is the PSA test, or the prostate specific antigen test. This test is somewhat controversial. It's been used for a long time, for maybe 20 or more years, and it's actually an easy test to perform. It's done on a blood test, and it produces a number, typically a number from 0 to a large number, 10, 20, above a number like that. Refers to the number of prostate-specific antigen units in the blood. Now, normally a man will have a low number or low PSA value, below 4, if the prostate is normal. Now, as a man ages, the PSA value may go up, even if the prostate is normal. Now, the prostate-specific antigen may also increase in benign conditions where there's chronic prostatitis or other injuries of the prostate. So consequently, the prostate-specific antigen test is not particularly specific, and it has led to some concerns that it may lead to unnecessary biopsies and potential problems for men that don't actually have prostate cancer. It may also be elevated in prostate cancer that is low grade and non-life-threatening. Consequently, PSA could be a problematic test. However, on the other side, studies have shown if men are at high risk of prostate cancer, this is particularly if there's a hereditary predisposition to prostate cancer, or if the man is an African American men may be at increased risk of more aggressive prostate cancer. The PSA may be more useful in these particular groups, to monitor if a underlying prostate cancer is present. The other thing about PSA is it can be used sequentially, so that you could take measurements at different time points, and one could then track whether the PSA is rising or falling. And this could give a clue if there's a concern in the prostate. There are also other tools that can be used to evaluate the prostate gland, basically imaging. So ultrasound can be used, X-ray, PET scans, CT scans, and other types of radiological evaluations can be utilized to examine the prostate gland to determine if there is underlying cancer abnormalities. And also, if there happens to be a cancer that has spread to the adjacent tissues and invading around the adjacent tissues, such as the bladder, or to nearby lymph nodes. Prostate cancer also has the propensity to spread to the bones, and this can be particularly problematic. So the first thing in evaluating if a prostate cancer is present is to obviously determine, is there prostate cancer? And if there's a suspicion, really the only definitive way of proving that a prostate cancer is present is by pathological biopsy. So in a biopsy, basically cores of the prostate gland are taken, and then they're sent to a pathology lab for examination. In the pathology lab, the cores are fixed in formalin, and then they're embedded in paraffin wax and sliced really thin, placed on glass slides and stained. A pathologist will evaluate the cores to determine if there is cancer present. If there is cancer present, the pathologist will score the cancer by giving it a grade. This is basically called Gleason scoring. And pathologists will actually give two grades, one for the most common type of the cancer that the pathologist observes, and the second for the minor component, and then the grades are added together. The Gleason grades range from a grade of 1 to 5. The grades are then added up, and if the score is less than 6, this is considered a score of 1 or a class of 1, which is essentially a very low-grade cancer. Really, the types of cancers that are of concern for men are cancers that are category 3 and above. This is where the Gleason score is a 4+3 or higher. These higher grades of cancer have a much greater likelihood of metastasis and spread, hence the concern for identifying them. If a man has a low-grade cancer, the choice may be to basically observe that cancer to determine if it's changing or spreading. This can be called active surveillance or watchful waiting, where basically nothing is really done other than monitoring the man for new symptoms or perhaps measuring the PSA level over time to determine if it's increasing. If the prostate cancer is localized to the prostate gland, the treatment of choice is either watchful waiting or else surgery. If the cancer is localized to the gland, surgery can be used to cause complete removal of the prostate cancer and achieve a complete cure. So generally, surgery is only used in localized prostate cancer. Surgery can cause complications. It can interfere with the nerves that are surrounding the prostate gland, and this can lead to various problems such as incontinence or sexual dysfunction, such as the loss of erectile ability or other sexual functions as a consequence of nerve interruption. So surgery can be a difficult decision for a man to consider. There are different approaches to surgery as well, that there are older approaches where basically there's an anterior approach to the prostate gland where the belly is cut open and the surgeon will remove the prostate gland through an anterior approach. There are other approaches through the perineum where a surgeon can remove the gland through the perineum. In this approach, there is sometimes increased danger of nerve injury and other potential problems. Another more recent approach is using robotic laparoscopic surgery. In robotic surgery, the surgeon can utilize a robot to have more dexterity and remove the prostate gland through small incisions and remove the gland efficiently. So there's increased use and interest of the robotic surgical technique. If other approaches for localized prostate cancer include radiotherapy, so the cancer can be radiated with external beam radiation or other approaches. External beam radiation is the approach of applying X-rays, which are basically high-energy photons, which are focused on the prostate gland. So a skilled radiotherapist or radiation oncologist will basically identify where the prostate cancer is, and then will target that prostate cancer with a high-energy X-rays, which can be focused on that cancer and basically eradicate it through radiotherapy. There are different therapy techniques. Some are becoming more advanced, where there's modulated radiotherapy and different types of energy and fractionations that can be applied to the prostate gland to deliver that killing radiation to control the cancer. There's also some new techniques, something called proton therapy, where instead of photons being used, protons are used. Protons have a much more limited energy distribution, are thought to be able to perhaps deliver therapy in a more localized way and perhaps avoid side effects or damage to neighboring tissues. Proton therapies are only available at certain facilities, as not every location has access to a proton facility. There are other approaches to the prostate gland as well, that if a radiation therapy has failed, and if the prostate cancer has recurred, cryotherapy is an option. Cryotherapy is the process of placing freezing material into the prostate gland to kill the cancer with freezing. As I said, this is used in cancers that have previously been irradiated and have recurred, where radiation is no longer an option, because sometimes you can't re-radiate an area due to the toxicity of radiation therapy, can cause side effects or other problems in the localized area. I should also mention that localized radiotherapy can also be given by placing radioactive seeds into the cancer, and this is called brachytherapy, where radiation is placed directly into the cancer and can kill the cancer by locally irradiating the cancer. Now, if a cancer is spread beyond the prostate gland, this will require systemic therapy. How will a man know if the cancer has spread? So there's a few technologies that can be used to monitor cancer. So one would be a bone scan. A bone scan can be utilized to determine if the cancer has spread to bones. And prostate cancer has a particular predilection or interest in traveling to the skeleton and involving the bones, the skeletal bones. And this can be particularly problematic because if the cancer does go to the bone, it can cause weakening of the bone, it can cause bone pain, and it can cause pathological fractures. So a few ways to treat systemic prostate cancer include one using hormonal therapy, entolimab or other types of anti-androgen therapy are commonly used in endocrine responsive prostate cancer. And most prostate cancers begin as androgen-driven cancers, that these cancers are really androgen dependent, meaning that they use the male sex hormone, androgen and testosterone, to really grow, and that those hormones drive the growth. So anti-hormonal treatment is the use of drugs that block the endocrine hormones, the testosterone and the androgens, from binding with the receptors in these cancers and can block the growth. Now, one of the problems with these sneaky cancers is that over time, the cancers may become hormone independent or resistant, so they can actually escape hormonal control. And then this leads to a cancer that is now hormone independent. So what to do with these cancers? So these cancers are possibly treated with chemotherapy as they may become more aggressive, or there's some new treatments that are now available for these more advanced cancers that are radiopharmaceuticals. For example, one new one that has got some very significant success is a lutetium isotope that's combined with a target that's attracted to metastatic prostate cancer. And so this radioactive targeted drug is drawn to the metastatic cancer and will kill it with the radiotherapy. So this is quite exciting, using these lutetium that are both radio tracers that can be visualized with PET scans, but also can deliver toxic radiotherapy to the metastatic cancer. So a lot of interest in that. Radio tracers can also be used for treatment of bone metastasis. And so there are a number of radioactive compounds that can be delivered to a patient who has pathologic bone fractures or problems with metastatic prostate cancer in the bone. In addition, there are a type of drug called bisphosphonates that can also help the bone protect itself from metastatic prostate cancer, and these are getting uses as well. Some exciting developments in prostate cancer are the use of immune therapeutics. So there are some early studies that may indicate that certain prostate cancers may actually respond to immune checkpoint inhibitors, such as Keytruda. Now, some of those cancers would be cancers that show microsatellite instability. This is a particular type of DNA damage that often occurs in men who have hereditary type of prostate cancer in the Lynch syndrome. And if the prostate cancer has microsatellite instability, these cancers frequently develop neoantigens, which have autoimmune response. And then the cancer has found a way to shield itself by blocking the immune response with PD-1. So the PD-1 and PD-L1 inhibitors can overcome this blockage and then allow the immune system to then activate and remove the cancer. Now, we're only beginning to understand how prostate cancer may respond to immune therapeutics, and this is an area of active research that's ongoing. There are some developments also looking at vaccines, where vaccines are under scrutiny as being a potential therapy for metastatic prostate cancer as well. Now, one group of therapy that is getting some traction is the PARP inhibitors. And PARP inhibitors are effective in cancers that have a particular type of DNA repair problem called homologous recombination repair deficiency. So that's a real mouthful, homologous recombination deficiency. And this occurs in a group of men who have inherited mutations in DNA repair genes that are called the BRCA genes, or the homologous DNA repair pathway. There's actually many genes in the homologous recombination repair pathway. There's probably over 50 of them. And the most common ones that you might be familiar with are BRCA1 and BRCA2, but there's many other ones, RAD51, CHEK2, many other ones are part of this particular pathway. Now, what happens is in a man who has dysfunction of this pathway, who has inherited a faulty gene from one of their parents, and they have developed prostate cancer that has this particular feature of homologous DNA repair dysfunction, that these cancers will respond to PARP inhibitors. And there's a couple of PARP inhibitors that are currently being used, rusaparib and olaparib. And so these have been approved by FDA for use in men with advanced prostate cancer who have these DNA problems. Now, the importance about knowing about this is that the drug can only be used if the test has been done to determine if a man's prostate cancer actually has a homologous recombination repair deficiency. And so this can be done in two ways. So one, the man could have a DNA test done on their saliva or on a cheek swab, where the DNA repair genes are evaluated by next generation sequencing. So this is a technique that takes a few weeks, where you take the swab and the results come back. Now, when this happens, the panels can be different sizes. So some of the commercial panels are small. They may only measure, 4, 5, 10 genes. If they uncover a mutation in one of the genes, then that man would be eligible for a PARP inhibitor use. If those small panels are negative, there is a couple of other things that could be done. One, a larger panel could be considered where more genes are examined. I would recommend a large panel always be done if you are considering a hereditary cancer problem. By a large panel, I would recommend a panel that contains at least 70 genes, and ideally probably over a couple of hundred genes. You can also consider a test that's called a whole exome sequence, where over 22,000 genes are evaluated. And when you do that kind of comprehensive evaluation, you also get information about non-cancer genes as well. Now, DNA sequencing technology has taken off and is so available and is so efficient that I tend to recommend that the larger panels be done, because they are generally not really that much more costly to do, but they can deliver 100 times more information. And this information, as I said, can be useful for measuring and determining what to do with your current cancer. For example, if you're a man with prostate cancer, should you get a PARP inhibitor? But it can also tell you if you're at risk of getting other cancers, for example, colon cancer or pancreatic cancer, other cancers, if you do carry an inherited faulty gene. The other thing is, if you do carry that gene, your children could be at risk of inheriting that gene from you. And it would be helpful if they knew that, because if they had one of these inherited genes, their risk of certain cancers, prostate cancer, colon cancer, other types of cancers could be quite high, and they could take protective measures, which could be a lifestyle modification, could be prophylactic surgery, or it could be enhanced screening to make sure that they get those cancers at an early treatable stage. So certainly genetics have a big role in prostate cancer and should be considered. Now, one of the reasons that I highlight this in this discussion is that the knowledge about the role of genetics in prostate cancer has really been accelerating recently. Urologists may not be fully aware of the importance of genetic testing in prostate cancer, as it's really only been really recommended more recently that probably all men with prostate cancer consider having genetic testing to determine if they do have one of these genes that are driving the prostate cancer and can be used as a therapeutic target. So it is quite important that you might undertake that genetic test. Another test that can be useful in prostate cancer is a comprehensive genomic profiling. So this is where the prostate tissue is examined by, again, next generation sequencing to look at if there are any somatic alterations in the cancer. Now, somatic testing is different than germline. Germline is looking at all of the genes that you inherit from your mother and father, and it's done by analyzing either your blood, saliva, or a cheek swab. When you do a somatic test is done looking at the DNA from the tumor. Now, the tumor DNA contains both the inherited genes, but it also has acquired mutations through the life of the patient. They may have acquired mutations to certain genes, for example, as a consequence of smoking or radiation exposure, toxins in the environment, radiation, or other things could cause an alteration in the DNA of the organ. And this is called a somatic mutation. If the gene test is done, it has the possibility of uncovering certain driver mutations that can be targeted with targeted therapies. Some of these include things like the microsatellite instability that we talked about earlier. We could also uncover if a homologous recombination gene is somatically altered, and a tumor that has somatically altered homologous recombination could be a candidate for PARP inhibitors. Now, homologous recombination will also cause patterns of DNA damage called DNA scarring, where the analysis of the DNA can show that, wow, this DNA is showing the pattern of a homologous recombination deficiency problem. There's a lot of DNA copy number changes. There's something called loss of heterozygosity. So these patterns are apparent when you run one of these tests. And so the molecular pathologist or geneticist can say, oh, this pattern of DNA damage is indicative of homologous recombination deficiency, and therefore this cancer could be considered for treatment with a PARP inhibitor. Now, cancers may also have other types of mutations, for example, specific fusions, NTRK fusions, or other types of actionable mutations. An actionable mutation is a specific driver mutation. Driver mutation is an acquired mutation that an organ gets that leads to causing the cancer to develop, and that tissue becomes dependent on these driver mutations, and the targeted therapeutics can turn those driver mutations off. So by doing a comprehensive analysis of the tumor DNA, one can uncover if there is a driver mutation and whether a targeted therapeutic might also be an option. Generally, these are only considered in late therapy, and often they're available through clinical trials. So I also always encourage patients to consider a clinical trial, in that a clinical trial can give you access to effective treatments sooner than they'd be normally available to the general population. And patients that are enrolled on clinical trials actually generally do much better than patients that are not enrolled in clinical trials. So if there's an opportunity to get on a clinical trial, I strongly recommend that you consider that and take that opportunity. In addition, usually all of the costs of the clinical trial are actually covered by the pharma company, so there may not really be any out-of-pocket expenses for being on one of those studies. Now, another thing I'd like to talk about before I leave is the use of liquid biopsy. So liquid biopsy can be particularly useful in men with prostate cancer in that it can allow the detection of prostate cancer. We talked about PSA. PSA has some issues with sometimes false positives and sometimes false negatives too, in that some prostate cancers may be present and actually not cause an increase in the PSA. So that's why PSA is not by any means a perfect test, and also has sometimes some problems in having false positives and false negative. There are newer liquid biopsies that are looking at circulating tumor cells. Circulating tumor cells can be very effective in determining Is there underlying prostate cancer? Is that prostate cancer spreading or increasing in amount in a patient? Because the liquid biopsy can be done at different time points, for example, every 6 months, every 3 months. You can then look at, are the numbers of circulating tumor cells increasing? Are they changing? Do they still express androgen receptor? Do they have alterations in the androgen receptor in terms of, is there mutations in androgen receptor that might be indicating the tumor is becoming resistant? Or are there other targets emerging in those circulating tumor cells? In addition, cell-free DNA can also be useful in uncovering mutations that could be actionable, and again, in measuring load of the cancer in a patient. So, in summary, we talked about prostate cancer today. Prostate cancer is the commonest condition in men in terms of cancer, occurs in 1 in 7 men. The challenge of prostate cancer is it could be indolent, meaning that it really doesn't cause any problems at all, or it could be highly aggressive and lead to fatality very quickly. And this is one of the challenges, really distinguishing the two groups. We know that men who have inherited prostate cancer or have high risk or aggressive prostate cancer in their family should be particularly concerned. We also know that African American men are particularly prone to aggressive prostate cancer, and so they should also be aware of perhaps participating in enhanced screening or be more aware about their particular risk of prostate cancer. We also discussed that prostate cancer, if it's detected early, can be treated with surgery, which can cause or can lead to a definitive cure. There can also be use of radiotherapy for local control. If the cancer is actually spread, one of the first lines of treatment is endocrine treatment or anti-androgen treatment. Prostate cancer likes to spread to the bone, and so the endocrine therapy can help control the bone metastasis. There's also bone therapies that can be used in terms of bisphosphonates and other treatments that can block cancer from spreading to the bone, so those should be considered as well. There's emergence of radiopharmaceuticals that are really exciting in that they can specifically deliver radiotherapy to microscopic deposits of prostate cancer using lutetium that's combined with a type of prostate-specific antigen targeting molecule that can deliver that radiotherapy directly to the prostate cancer that has spread. There's also palliative cares, treatments that can be used for controlling bone fractures with radiotherapy and targeted therapy to fractured bones, and also approaches to stabilize bone should there be fractures in the bone. Now, prostate cancer can have a very, very long duration in men, so even if it's spread, it can be controlled for many, many years with these advanced technologies, and the symptoms can be very much controlled. So there's definitely a lot of care that can be delivered to men with metastatic cancer. In terms of novel therapies, there's a lot of excitement in immune therapies, vaccines, PARP inhibitors, which, remember, for the PARP inhibitors, you do need to get that genetic test to see that you're eligible for a PARP inhibitor. There's also the targeted therapies, and again, you need to have a good molecular analysis of your tumor to determine if you can be eligible for one of these targeted therapies. Plenty of clinical trials. Always consider a clinical trial and one that's right for you, particularly a targeted therapy or an immunotherapy trial, I'd strongly encourage. So a lot of developments there. And also the exciting advances in liquid biopsy, where the prostate cancer can be measured using blood tests and other approaches, so that over the course of the disease treatment, there can be an accurate evaluation of how the cancer is responding to the treatments, and if that cancer is changing, and whether therapy should be altered as a consequence of the change of that particular cancer. So I hope you found today's discussion useful about prostate cancer. Again, please visit our website. There's opportunities for you to give feedback, give us suggestions, perhaps questions or suggestions for future episodes. Thank you for tuning in. I'm Dr. Tony Magliocco, and I'm the Cancer Informant, and I look forward to connecting with you again in a future episode. Have a wonderful day. Bye-bye.